Okay, I think we're ready.
Am I starting?
You are starting, you're live. We're ready for you. David, can you hear me?
Done this before, so please excuse if there are some hiccups. So I'm going to talk today about body dysmorphic disorder. And my name is David Veal. I'm a consultant psychiatrist in cognitive behaviour therapy. I'm based at the Maudsley Hospital and Bethlehem Hospital, and I'm also based at the Priory Hospital in North London. And what I want to try and explore today partly is this idea, I guess, from the picture in Picasso, in which there's a woman looking in the mirror and she's seeing something different to what she looks like. And this is the most difficult problem, I guess, to explain. How someone with BDD can look in the mirror and see something which other people can't see in the same way or feel in the same way. My own view is that BDD is a public health problem. We know that most people who suffer from BDD also suffer from depression, about 2/3. About 1/4 have attempted suicide at some time in their life. And generally, people with BDD have a high suicide risk. And the best data there is from Catherine Phillips, which estimates from one study about 0.3% of people with BDD per annum commit suicide. People are generally more likely to be unemployed or disadvantaged. They may be housebound. There are often difficulties in relationships, and it's a chronic problem. There's an average of about 15 years often before they're actually seeing mental health professionals. Generally, there's a poor recognition by health professionals. There's a lot of stigma, I'm afraid, against it. For example, if you've got a physical disfigurement, it's much more understandable, and people are going to be a lot more, much more likely to help you, perhaps. And there's also self-stigma by sufferers of BDD because of the fear, perhaps, of being viewed as vain or narcissistic or something. And sufferers are therefore more likely to seek help from dermatologists or cosmetic practitioners. And generally, there's low funding for research and lack of specialist services. So, for all those reasons, I do see it as a major public health problem. But I don't want to be too depressing today, because actually I still think there's a lot that can be done. So just to define what we mean by body dysmorphic disorder first, the key feature is a preoccupation with a feature, or usually more than one feature, that others don't find that noticeable or that abnormal. And by preoccupation, the cut-off point is usually at least an hour a day at the forefront of your mind. Sometimes, of course, it's difficult to estimate that, but it's something generally that most people find that's on their mind several hours a day. It must be significantly distressing or interfering in your life in some way. In other words, this is not just something being an adolescent and being worried about not getting a date or something. It really is significantly distressing and handicapping. And the diagnosis, the symptoms mustn't be better accounted for by another mental health problem. So, for example, people with anorexia and eating disorders tend to exclude the diagnosis of body dysmorphia. That's not to say that, sometimes you do get people with eating disorders having both eating disorders as well as body dysmorphia, but that's a little bit more complicated. Is it an obsession? Well, it's not strictly, because in the psychiatric terminology, it's better described as a preoccupation. It's, as I've said, time-consuming, painfully distressing, difficult to resist, handicapping, and stigmatizing. And, I guess across tonight is the notion that this is a body image problem. Now, I can't show you the photograph of this young woman, who was a perfectly attractive young woman, but, I asked her, and I asked all my patients, to try and do a self-portrait to convey how they're feeling about their appearance. And I think this really was able to allow me to really understand the way that this person particularly felt. So she felt her hairline was too far back, and lots of multiple preoccupations of different defects in her body. Ugly eyes, veins, facial hair, cleft chip, so on and so on. And it just bore no resemblance to how she actually looked, because when we show you the next slide, this was after therapy. You can see that this is a nice little outcome measure, because you can see that her now back to normal in terms of how she feels about her appearance, and that this is hopefully give you some hope that treatment does work, can work. This is somebody else who drew themselves looking a little like a sort of Mekon from an old comic. And here was important because although he didn't actually have a visual image in his mind as to how he looked, what he had was a felt impression of heaviness on his head. And so it felt as if his forehead was very big in this particular way. So, this is a very good example, again, as a body image problem. What causes BDD? Well, the straight answer is we don't know. Like most mental health problems, it's complex. There are many factors which, again, are not necessarily specific to BDD. In other words, the same things through, let's say, some sort of emotional abuse or neglect in childhood may well go on just to cause depression or something else without BDD. And, body image is a complex phenomenon. It's not just like a photo on the back of your eye. And really what you see in the mirror is what you construct, whether you've got BDD or not. And body image depends on sometimes ghosts from the past, how you feel now, what you believe, whether you're excessively self-focused, how you're acting, what you're behaving, all sorts of things. All these things contribute to what we see as body image. And so, there are probable risk factors in terms of leading to a body image problem like BDD. So at the top there you've got family or cultural values. Sometimes some families might put a lot of emphasis on the importance of appearance in defining who you are. And, you might just pick up as a child all sorts of things about how beauty or appearance is actually what counts. Sometimes I think there are cultural values, and certain cultures put a lot more emphasis on appearance. You may, if you go around the right, you may be more born in your personality, perhaps quite shy or socially anxious, have a low self-esteem generally, or go down the perfectionism route. That's generally actually more a minority of people with BD who have sort of perfectionist traits. Some people we find are more aesthetically sensitive, and by that I mean that you are more likely to appreciate art and design and beauty and so on, and that we've got some evidence for that, and that quite a few people with BDD they're more likely to have a background in art and design, or be graphics designers, or training as an architect, or things like that. A lot of our patients have had a history of being teased or bullied in childhood or adolescence, not necessarily about their appearance, but just some sort of teasing or bullying. And again, it's clearly not specific, because lots of children are teased and bullied. I can remember being teased about my height once when I was young, but I don't develop BD and I don't have a mental health problem, so it's clearly non-specific, but it certainly comes up a lot in histories of people with BD. There may be a genetic predisposition, we just don't know. Certainly you do see in some families quite a history of either BD or obsessive compulsive disorder and other anxiety disorders and depression. And lastly, there may be other non-specific childhood bad events, whether it's emotional abuse, emotional neglect, sometimes physical abuse, or physical abuse. So at the moment, all of those things, as you can see, are rather non-specific, but it may be that being aesthetically sensitive may be something that's more specific about BDD, and that's again only in some people. What keeps it going? Well, one of the things that we're very aware of is this excessive self-focused attention. And excuse me, from a little sculpture I saw at once, I think at Chelsea Flower Show, where you can see someone, looks like, yes, it really is his head up his bottom, but it's more about being in your head, living in your head, and getting all your information from the world, from what your mind is telling you. And so you can imagine from those pictures, if you've got that sort of picture in your mind or a felt impression of how you look, and that's what your mind is telling you all the time, and your focus of attention is internal, that's, as far as you're concerned, is like an internal mirror in terms of how you look, and you're extremely aware of it. And you may then go on to, not surprisingly, view yourself as rather ugly because of that picture in your mind. You tend to ruminate about it and analyze it and think, why was I born this way, and if only I hadn't had that surgery or whatever. Trying to find reasons for the way you feel you look, and constantly comparing those features with people with perhaps the same sex and age, and where you stand to them, constantly sometimes self-attacking yourself and putting yourself down, and trying to generally identify yourself through your particular feature. And the way I represent that is a great picture I came across of, I think this is some drug advertisement for clear noses or something. I thought that is just the way that someone perhaps worried about the features in their nose or something sees themselves. You know, I am just a nose, that's all that I am. And this is clearly a very BDD type of way of seeing things. And the other thing that seems to happen is that when you are focused externally, you tend to perhaps focus on the specific features compared to your overall appearance and yourself as a person. And you tend to have lost your rose-tinted glasses. You know, one of the interesting things is that healthy people who don't have BDD tend to see themselves actually as more attractive than they actually are. You know, it's actually healthy people who are deluded. Now, of course, this is only a slight bias, but again, it's another thing that seems to contribute to the development of BDD, where perhaps you might lose those rose-tinted glasses and see the world or see yourself actually more real than perhaps others do. And then, of course, there's all these what we call avoidance and safety-seeking behaviours. So, again, all these things tend to keep the problem going and prevent you from testing things out and getting anything positive in life. So you're avoiding lots of social, public situations. And if you do go into social, public situations, you're probably using lots of safety-seeking behaviours, or sometimes compulsions, mirror-checking, camouflaging, trying to distract attention from yourself, having a poor eye contact. You might be using, for example, your clothes or your hat or hair to hide a particular feature. You might adopt a certain posture, alter your profile, using excessive makeup, padding, cold Coke cans to try and reduce redness on your skin. I mean, there are hundreds of things that people with BDD may do, which is, you know, every person with BDD that I meet, there's always something new that I haven't come across before. But all these things involve enormous amounts of mental effort and attention, and they all feed the preoccupation and the distress, because they all have to be monitored and just to keep the problem going. And of course, many people with BDD seek cosmetic procedures. And you know, if you have a picture in your mind like that, it's not surprising that you're going to try and find ways of rectifying it in that particular way. So the best thing we can say now is that if you've got a diagnosis of BDD, it makes satisfaction from the surgery unlikely and unpredictable. You may be satisfied if it's an unambiguous type of operation, for example, breast reductions and enlargement. At best, therefore, you say, you may be satisfied with that type of a procedure, but if it's multiple defects, or particularly around the nose and so on, it's very unlikely to alter the symptoms of BDD, or the focus of the preoccupation just may alter to something else. At worst, it may make your preoccupation handicap worse and leave you with a lot of debt. In general, what we usually say, if you're absolutely determined to have cosmetic surgery against advice, it's usually best to delay any other treatments until after the surgery. And, the saddest cases I think I've seen are people who've been so desperate to try to change their appearance that they've done what we call DIY cosmetic surgery. So we have seen people in the past who have, this gentleman pinched and stapled his skin to have what was called a rhytidectomy, that's a facelift. He narrowly missed his facial nerve. Filing down teeth to alter jawline, someone who was super gluing their ears to pin their ears back, sandpapering their skin to what was called the dermabrasion, trying to exsanguinate, that's to lose blood, to make themselves look paler, someone who was cutting themselves to release fat for liposuction, and someone even used an iron to remove their wrinkles. These are really sad, desperate cases, and it just shows how awful that this condition can be. Now, one of the best things that did come out for BDD was actually the NICE guidelines, because it has put it on the map, and it actually, even though we don't yet have a lot of evidence compared to, say, obsessive compulsive disorder, it's on the agenda, and there is something out there saying this is how it should be treated. And what it essentially says is very similar to OCD. That is, if you have mild problems, that's what they call mild functional impairment, then you should be offered brief cognitive behavior therapy. And if you have moderate functional impairment, you should be offered a choice of cognitive behavior therapy or an SSRI, suppressant medication, which I'll talk about in a minute. Or if you've got severe functional impairment, you should be offered a combination of two. Thing to emphasize here is that it's a choice, and that even after local treatment, perhaps a CBT or an SSRI or whatever, if it's still not working, you should be referred onwards and upwards to more specialist centres. So, first thing to say, and I'm just going to try and focus on the things that I know that a lot of people with BDD who want help get very frustrated, because they feel that perhaps they haven't always got the right type of CBT, probably quite correctly. So cognitive behavior therapy, CBT, is not like Prozac. In other words, if you tell me that you've had a trial of Prozac at a particular dose for, say, 12 weeks, and it hasn't worked, we can safely say that this particular drug has not been of any benefit to you. But if someone tells me they've had CBT for say 10 sessions and it hasn't worked, it's very difficult sometimes to work out, well, what exactly did you receive, what was the quality of it, and was it really specific for BDD and not something that was generic CBT. And I have to say, and being hand on my heart here, the standard of CBT in the NHS or the private sector varies a lot. And there are some great therapists who are really sticking to the protocols, and there are some really poor things that go in the name of CBT. In general, try to look for a therapist that is accredited or accreditable by the BABCP, that's the lead body for cognitive behavior therapy, and who will tell you that they will follow a protocol of a treatment manual for BDD. And if you failed locally, then ask to be referred to an OCD, BCD specialist clinic. The one I work at is the outpatient at the Malsey Hospital, or a residential unit at the Bethlehem. And we're trying to put together a list of other centres which are more specialist centres around the country. And there are a few, but not very many. If you want to go down the private route, then probably the best thing to do is go to this register of at least accredited therapists. But again, talk to them in terms of their experience in BDD and whether they'll follow a particular treatment manual. The key thing, I guess, for cognitive behavior therapy for BDD is not treating it as an appearance problem, because very likely you've treated this as an appearance problem for 10 years or so, and it's not working. You know, it's actually what we'll say, you know, the solutions that you've been using are the problem, which actually feed the preoccupation and the distress. And you've got to really commit yourself to treating this as a body image problem in order to decrease the preoccupation, the distress and handicap, and actually be able to do what's important in your life. So what we say, for good CBT for this particular problem, we would try to target the felt impression, the imagery, in terms of often it's associated with some of the ghosts from the past, and we really target some of what we call the processes of self-focused attention, helping people to focus more externally on what's going on around them, the ruminations, the comparing, helping people to drop the safety-seeking and avoidance behaviours gradually, bit by bit. It's tough. It's a lot of blood, sweat and tears to try and, you know, unlearn a pattern of thinking and behaving that's been with you for many years. But it's definitely possible to change, and it's definitely possible to get a life back. Just a few notes on if you're struggling to get treatment. There is a good now advocacy helpline, OCD Action, which can help you, guide you through the maze of getting help in the NHS. There is the nice guidelines on BDD, which you should arm yourself with in terms of actually, if you're getting questioned on, you know, what the problem is and why you should get this particular treatment. There is a constitution in the NHS that says, you know, about how you can get help and referral to the choice of your particular treatment centre. And there is always, most places got a PALS, which is your patient liaison service, where it can give you advice on health and complaints, on how to get through the maze. If that fails, there's also a health ombudsman to make complaints to, or contact your MP. It is possible. Sometimes it takes, you know, a bit of struggle to get through, but, you know, all those things can help. In terms of medication, if you're going to be on medication, the NICE guidelines and the evidence seems to be in favour of those dear SSRI medications, and they've given you some examples there of them. Mostly, in general, it's probably requiring higher doses than you need for depression, and at least 3 months duration for a proper trial at a higher dose. One of the problems, we don't yet know this fully, but there's probably a high rate of relapse if you then stop taking it early. And you may then need to be on it for at least probably a year or two. And I would say, you know, combining it with the CBT as well. Some people are prescribed antipsychotics. These are things like olanzapine, risperidone, quetiapine, and so on. These at present are not indicated. There may be a few rare cases, but in general, the NICE guidelines say that antipsychotics are not indicated. There's no evidence that they do any good at all for people with BDD. So if your therapist wants help of a treatment manual protocol, there is, on the left you can see Body Dysmorphia Treatment Manual, a book we've written for therapists, for professionals about BDD and how to treat it. If you're a sufferer, I wouldn't look at that, because there's lots of horrible long words and models and so on, unless you're really dedicated. That will be coming out in the end of March, I think. And we've done a condensed version with easier language for lay persons on the right as a self-help book, which will give you an overview and self-help steps for CBT using for BDD. And that's it.
Okay, David, can you hear me?
So
David?
I've finished my presentation, and I'm now going to be able to take lots of questions.
Okay, well, I think David's having a bit of a problem hearing
You can see
me,
my
but,
daughter there. Yeah. No, you're right. I'll put my speakers on now.
Can you hear me now, David?
Yep.
Okay, sorry about that. David, we've got quite a few questions, if you don't mind.
Sure.
I'm going to read them out to you. Okay, so the first question here, it says, my 20-year-old daughter is very attractive. Obviously, I'm biased, but many people tell her and me how beautiful she is, tall and slim. Sometimes she thinks she is so hideous that she won't go out. But if she has to, she will cover as much as possible of her face up with a scarf because she thinks people will look at her hideousness. She has OCD. Do you think she could have BDD?
Well, it certainly sounds like it, because it certainly sounds as if she is very self-conscious and very preoccupied by it and using lots of these avoidance and safety-seeking behaviours. And if you've already got OCD, OCD and BDD often go together. So I would certainly discuss that with any doctor or health professional therapist that she's seeing at the moment and get it. I'm surprised they wouldn't necessarily pick that up, because if it's so obvious in a particular way, you'd have hoped that they would be asking the right sort of screening questions.
Okay, thank you, David. Also, David, we can still see your screen, by the way, just so you know.
So what do you want me to do?
Oh, you can put your slides up if you want.
Oh, all right.
Your screensaver's recorded. There's another question here. It says, for very severe BDD, how often would you recommend CBT for someone who has already failed with CBT and medication?
Well, you see, that was what I was saying before. It's easy often to judge whether you failed medication in terms of various SSRI medications and so on. And there are often other medications you can take. But in terms of CBT, it's so difficult sometimes to judge the quality of the CBT that you've had. So unless it's actually, until you actually talk to someone who's a specialist in the area and find out exactly what understanding you had about how this was caused and what procedures were done and so on, it's very difficult. So I would still always go back again and ask for a second opinion to see someone else who's a specialist in this area.
Okay, thank you. There's another question here. It says a lot of people have body image concerns. When exactly does that become BDD?
Yeah, good question. The nature of BDD is essentially a preoccupation. It's on the forefront of your mind for at least more than an hour a day. So that's the first thing. The second is it must be significantly distressing and handicapping. And that's a clinical judgment. But usually it's not too difficult to make that sort of judgment. And lastly, it mustn't be a body image problem perhaps that's related to an eating disorder or something else. But those are the three main criteria to decide whether this is normal body image concerns.
Okay. There's a question here. It says, is anything being done to help recognize BDD in adolescence? I might just add to that. Sorry, I might just add to that an extra one, which is about is BDD more common in adolescence, and do they normally grow out of it?
BDD tends to come on during adolescence. So, as the questioner rightly pointed out, having body image concerns is fairly normal in adolescence. And that's a time when we're all more sensitive about our appearance, and it's so much more important to us. So it's a little bit more difficult sometimes to decide what is normal body image concerns and what's BDD. But so we're certainly trying to do our bit to try and get child and adolescent psychiatrists and mental health therapists and so on to recognise it more, because one of the problems often, certainly being in the adult services, is that people don't necessarily ask the right questions. And one of the problems in BDD is that if you don't ask, if the mental health professional doesn't ask, you don't get, because people with BDD are very reticent and they're much more likely to present, shall we say, with depression or feeling socially anxious or some OCD or something, which are all sort of conditions which are less stigmatizing, and people almost prefer to present rather than actually the real problem.
Okay.
So I think so. It's two things. One, mental health professionals need to ask, and people with BDD need to tell more.
Okay. There's a question here from someone. It says, what's proven to be the most effective combination of medications for treating BDD?
Well, one of the problems in BD is so little research has been done. And, you know, at the moment, the best evidence, I'm afraid, is the SSRIs. If one doesn't work, it's worth trying a different one, trying to get to the highest possible dose, sometimes using other medications that might be helpful in OCD, which is difficult to go into in all the details now. But the most important one, trials, first of all, are the SSRIs in the maximum tolerated dose.
Okay, there's a question here. I think you kind of touched on it in one of your first slides about preoccupations. It says, what is the difference between an obsession and a preoccupation? Is it just how strong the feeling is?
Oh, well, we tend to use the term obsession for very specific things to do with obsessive compulsive disorder. That is recurrent intrusive thoughts, images, doubts and fears of harm, particularly things like contamination, or the idea that perhaps you might be a paedophile, or the thought that you've left the gas cooker on, things like that. Whereas preoccupation just describes the notion that it's on the front of your mind a lot. And, you know, you can have a preoccupation with jazz music, or you can be preoccupied with something else. It's just, it means it's on your mind a lot. That's all it means.
Okay, David, there's another question here. It says, if someone has been successfully treated for BDD and feels on top of it, are there any things that are likely to trigger a relapse?
Sure. Comments about your appearance, things like that. I'm trying to think. I mean, usually the sorts of things that you might be sensitive about before you developed a problem are the things you might be sensitive about later. So you might want to have some sort of relapse prevention plan in therapy to actually try to identify the sorts of things that might make you at risk, so that you can practice and prepare for them. Where, say, someone making a comment about some aspect of your appearance or something, and you know, and thinking through how you're going to deal with that sort of thing.
Okay, David, whilst I can see a couple more people thinking about asking a question. Can you just explain a bit more about the relapse prevention, because it is something we get asked quite a bit. And how does the process work? Of developing your own techniques.
It's a very individual thing, because in therapy you want to be able to identify the things which that particular individual is vulnerable to, so that you can then work out how to deal with it if and when it comes up. So if you know that your parents are generally critical, or might throw all sorts of rubbish at you in some way, for example, then you want to perhaps practice doing that in a role play. So it's almost like perhaps your therapist being that particular critical parent or whatever, and practicing how to deal with and rebutting their particular comments.
Okay, there's a question here. It says, is BD treated in GP surgeries? And I guess it might be useful just to explain what would happen if you went to the doctor and you were diagnosed. Where do you go? What happens next?
Well, I think we can generally say that BD isn't treated at doctor's surgery unless you're just wanting the medication. And most places, increasingly, certainly in the UK now, have what's called increasing access to psychological therapies centres. And in most of those centres, when they're up and running properly, should have access actually without a GP. So you can actually refer yourself, or you can go through your GP. And I know that not everywhere in the UK has got them up and running now, which is in February 2010, but I think over the coming year, certainly there will be much better access to psychological therapies.
Okay, thank you, David. That's the last of the questions we've had submitted. So thank you very much to everyone who's been attending and sending in their questions. And thank you very much, David.
Okay.
Thank you very much. Bye-bye.
All right. Bye.